my pleasure to introduce Dr. Nisha Bansal, who's actually an assistant professor of medicine and a nephrologist at the University of Washington in Seattle, so not a far place. But she's also the associate program director and active member of the Kidney Research Institute, which has an innovative program of translational and epidemiological and trial studies. And we have threatened to collaborate with each other over a period of time, the University of British Columbia and Washington. And you'll remember that we had the combined pathology rounds earlier this year. So while this is not a combined rounds, hopefully it's the beginning of another group. So Nisha has done a lot of work with the CRIC group, as well as has a major interest in cardiovascular disease and kidney disease. And we're going to hopefully have a good discussion after this talk. So welcome.
Great. Thank you, Adia. It's a real pleasure to be here today. Thank you for inviting me to speak with you all. I've really enjoyed my visit so far. So today I'll be talking about implantable cardioverter defibrillators in patients with kidney disease. So, as always, it's always nice to bring this back to the patient. Let's talk about a patient. So this is a patient I saw in clinic who is referred to me by the cardiologist. 64-year-old man with a history of diabetes, end-stage renal disease, has been treated with hemodialysis for the last 5 years. He has known coronary artery disease, and he was diagnosed with heart failure with reduced EF about 6 months ago, and his EF remains persistently low. So the cardiologists refer him to me and say, what do you think? Should this patient have a primary prevention ICD placed? His risk for sudden cardiac death is high, and he meets our ICD criteria. So that's my first question to the group. I won't poll you to put anyone on the spot, but think about it as we discuss the data. My second question to you is, would your answer change if he was not on dialysis, but rather a pre-dialysis patient with chronic kidney disease with an EGFR of 35? So I want you to keep this patient in mind as we talk about some of the data surrounding these issues. So over the next during my talk, I'll review generally the prevalence and incidence of heart failure and sudden cardiac death among patients with kidney disease, both ESRD and those with CKD. Talk about the data we know about rates of ICD implantation in these populations, and then finally outcomes after ICD implantation in patients with CKD and ESRD. So heart failure. So we know that heart failure is actually one of the leading causes of cardiovascular disease in patients with chronic kidney disease. We did a paper that was published last year of 18,000 patients in the community, and we compared rates of 3 types of cardiovascular disease: heart failure, coronary heart disease, and stroke amongst patients without CKD, denoted by the black line, and those with CKD, denoted by the gray line. You can see that the rates of all 3 types of events are significantly higher amongst those with CKD. And in particular, we see that the rates of heart failure and coronary heart disease are nearly equal, which differs than what we see in the general population. And then if you look at the risk difference, meaning the difference in the height of those bars, you can see it's greatest for heart failure, meaning that there's an excess risk of heart failure compared with other cardiovascular subtypes amongst patients with CKD compared to those without. And then if you look at it from the opposite direction, because we know there's this sort of bidirectionality, there's 6 million patients with heart failure in the US. I'm not sure what the rates are in Canada, but I'm sure they're quite high as well. And a third of them have chronic kidney disease. So this represents a huge population, those with CKD of heart failure and those with heart failure who have CKD. And we know that sudden cardiac death is one of the most common and serious complications of heart failure. For the nephrologists in the room, it's defined as an unexpected pulseless condition attributable to the cessation of cardiac mechanical activity. It's estimated, at least in the U.S., that we think there's about up to 500 cases of sudden cardiac death per year. Again, this is often very difficult to ascertain, as many events occur out of the hospital or unwitnessed, and we never really know what was the cause of death. But that's, as far as we know, those are our estimates. And data from different sources has shown that sudden cardiac death is even more common in patients with CKD and ESRD. There was a study that looked at a clinical trial population and saw that even amongst patients without CKD, but those with relatively normal kidney function, that every 10 ml per minute decrease in eGFR was significantly associated with a higher risk of sudden cardiac death. And so what about in the dialysis population? So we have data from USRDS looking actually across all stages of kidney disease, pre-CKD through dialysis. And the USRDS is the United States Renal Data System, which is a national registry of CKD patients that's quite good at monitoring those, particularly on dialysis, in terms of what happens with these patients. And this is looking at the adjusted rates of sudden cardiac death per 1,000 patient years at risk. And you can see that there's this really strong stepwise graded increase in the rates of sudden cardiac death as your kidney function declines. And then this is data from the MADIC-2 trial, which is a trial that was done in the 1990s, which evaluated defibrillators versus optimal medical therapy at the time for treatment in patients with reduced ejection fraction heart failure. And so amongst this population across both groups, pre-randomization, they looked at what characteristics most strongly predicted sudden cardiac death amongst all these patients, this clinical trial population. What you see here is that eGFR categories, particularly the lowest category, this less than 35, was, out of all of these risk factors, was in fact the strongest predictor of sudden cardiac death with a hazard ratio of greater than 2. And then looking more closely at the dialysis population, we know that not only there's a higher risk of sudden cardiac death, but the timing actually makes a big difference as well. This is also data from the United States Renal Data System. This is data from Chuck Herzog, who's a cardiologist who's quite involved with the care of kidney disease patients, where reported some interesting trends where he looked at the months after dialysis initiation and, again, rates of sudden cardiac death. What you see here is that there's this sharp increase in the first 3 months after starting dialysis, which we've now recognized as a particularly vulnerable time in the trajectory after dialysis initiation. And a lot of that is thought to be due to high rates of sudden cardiac death. After 3 months, it's sort of amongst the survivals, it sort of levels off, but remains quite high in terms of rates of sudden cardiac death. So why is that? What is making our patients so vulnerable to this? So, there was a review that was published several years ago, and I really liked how they set this up in terms of thinking about the kidney disease patient as a vulnerable substrate. And then on top of that vulnerability, you have an inciting event. And the combination of these factors then puts them at high risk for sudden cardiac death. And so in terms of our vulnerable substate, in terms of our patients with CKD and ESRD, we know that there's structural remodeling that involves myocardial fibrosis, myocardial capillary mismatch, which leads to tissue ischemia, endothelial dysfunction, and vascular calcification. In addition, there's abnormal electrophysiologic remodeling as well, with slowing of conduction velocity and differences in zones of repolarization in the heart. So you take that in terms of our vulnerable substate and you add these pathophysiologic triggers, things like ongoing ischemia. We think that there's a high burden of unrecognized and subclinical ischemia in patients with CKD and ESRD, sympathetic activation, and then inflammation. And then for the patients treated with dialysis, talking about triggers, I mean, you're subjecting them to dialysis 3 times a week where there's these massive electrolyte shifts, hemodynamic changes, and the culmination of all of this in terms of their vulnerability as well as these triggers really leads to sudden cardiac death. So to summarize what we've talked about so far, we've shown data that shows that heart failure and sudden cardiac death are common in patients with kidney disease, and we think that kidney disease patients have unique pathophysiologic alterations and triggers that put them at higher risk for sudden cardiac death. So knowing this, are patients with kidney disease actually receiving ICDs? And I put in this term renalism, which I'm sure Adira has heard of. It's a term that was coined by Glenn Chertow, who's a nephrologist at Stanford University, a number of years ago with this idea that there's this intrinsic bias against patients with kidney disease where they may not appropriately receive cardiovascular procedures and devices at the same rates as other patients. And so what are the indications for primary prevention ICD? So ICD implantation is considered standard of care for the primary prevention of sudden cardiac death in patients with reduced ejection fraction heart failure. And they have to meet these criteria. They have to have a low persistent EF. Which cutoff you use has been debated, but I think the most recent one says less than 30%, despite receiving optimal medical therapy. At least a 40-day period following an MI, as it may improve. Heart failure that's persistent, at least 3 months in duration. No evidence of advanced New York Heart Association class symptoms. And you have to be at least 90 days out from CABG. So in terms of thinking about how many of our patients on dialysis are getting ICDs, so there's data, there's also a National Cardiovascular Disease Registry in the United States, which tracks how many ICDs are placed and some characteristics around the placement of these ICDs. And so one study looked at this data over about a 2-year period, and they saw pretty high numbers of patients who had a first-time ICD, so over 164,000. So you can see this is a fairly common procedure. However, only 4.4% of those patients were on dialysis. And based on what I showed you earlier in terms of these extraordinarily high rates of sudden cardiac death, you can see that dialysis patients appear to be underrepresented in this pool of patients who are receiving ICDs. And furthermore, those who were on dialysis were more likely to receive a non-evidence-based ICD, meaning they didn't fulfill all those criteria that I showed you earlier. And data has pretty strongly shown that if you don't meet all those criteria, you're less likely to derive benefit from an ICD. And then this is complementary data from the Renal registry. So that was a cardiovascular registry. Now this is a renal registry over a 12-year period that looked at rates of ICD over calendar years. And so this is going from 1994 to 2006, and these are the absolute numbers of ICDs on the y-axis here. Those in the light bars are primary prevention ICDs, while the dark bars are secondary prevention. You can see that, back in 1994, the rates were extraordinarily low, especially for primary prevention ICDs. They remain low, but I think there is some hope that there is an increase in terms of the number of patients that are getting these devices. So what about patients with CKD? Are patients with not on dialysis getting ICDs? And so this is data from over a 3-year period from the National Cardiovascular Disease Registry, which breaks down the proportion of patients out of the total pool of patients who received an ICD, how many of them had CKD. And I highlighted it by class, and you can see that altogether less than 2% of patients who received an ICD had chronic kidney disease in the United States over this 3-year period. There are some caveats to this data. One, there was a lot of patients with missing creatinine, so they were not able to actually identify if they had CKD. And then even for those who had creatinines available, when it is in relationship to timing of the ICD, if they're having a heart failure exacerbation, they're admitted, they're not in steady state. So there are some issues with this, but that I wanted you to be aware of when thinking about these numbers. So we tried knowing that the data in terms of the rates of ICD implantation, CKD, are not well defined, we tried to quantify this a little bit more rigorously. And so we embarked on a series of papers, which is called the risk study. And our first question we ask are CKD patients less likely to receive an ICD compared to those without CKD? To do the study, we studied almost 19,000 patients who had confirmed heart failure with reduced EF, who are all eligible for an ICD implantation, checked all those boxes that I showed you earlier. This was based on these healthcare management organizations in 4 different states, and these are patients who receive their healthcare through these groups. Since I was a nephrologist involved in this, I was pretty rigorous in terms of how we defined CKD. So we only used eGFRs that were from ambulatory, non-ED laboratory values, no inpatient eGFRs, nothing from the emergency room, and we needed at least 2 values 6 months apart to define CKD. And so this is the overall distribution of eGFR in our study population. So you can see about half did not have CKD and a half had CKD, which seems to make sense to me in terms of thinking about rates of, especially in those with such a reduced, with low EF, I would expect a lot of CKD. And so this is looking at the overall rates of ICD implantation during the study follow-up. So overall, the rate was 5.78. And then we saw that amongst, if you look at this column here, that really it was this group less than 45 where we saw lower rates of ICD implantation. We then did multivariable modeling, and we saw that those in this less than 45 group were about 31% less likely to receive an ICD compared to higher eGFR ranges. And really the difference is when you look at these patients, if you compare them, I mean, this group tends to be older and just have higher comorbidity, which may have led to some decisions in terms of not placing the ICD. So to summarize this section of data, really our data and data from others suggest that patients with CKD and ESRD are less likely to receive an ICD despite meeting clinical indications. So why is that? Why do we think that these patients are not receiving these devices appropriately? So one, it's been thought that they're more likely to have procedural complications, things like hematomas, infections, and other complications. Two, it's thought that they might be at a higher risk of long-term complications, things like infections and inappropriate shocks. And then finally, I think the big question is efficacy. Do these devices actually help patients who have CKD and ESRD as we subject them to yet another procedure? So questions on, does this keep them out of the hospital in terms of heart failure and actually reduce their mortality? So first, we're going to look at some data on dialysis patients in terms of rates of complications and outcomes after ICD implantation. So in fact, data has shown that patients on dialysis do have higher rates of complications with an ICD implantation. And I was really quite taken back when I saw this number. So the rates of infection are incredibly high. I mean, you can see here the incidence rate is 988 per 1,000 person years. And nearly everybody gets an infection, and then which it remains high in subsequent years. And they continue to have issues with this. This was another analysis that looked at dialysis patients comparing rates of in-hospital complications within 2 days of implantation of an ICD. And you can see that patients with ESRD really had higher rates of almost all types of complications. This is the composite summary that they show here. And these are percentage of patients. So 3.7% of patients with ESRD within 2 days of an ICD implantation had a complication. And these are some of the complications that they looked at. And then even more meaningful, people have looked longitudinally. So these patients are having more complications. Are they actually is it worth it? Are they getting any survival benefit? And in fact, so this is an analysis which matched patients on dialysis who received an ICD compared with those who did not receive an ICD and looked forward. And you can see these lines are on top of each other. So really no survival benefit in this group. And this was also confirmed this is a meta-analysis that looked at pretty small meta-analysis, which shows you there's not a lot of data on this, but 89 patients on dialysis, and then compare them to 2,500 patients not on dialysis, all of whom received an ICD. So everyone in this group received an ICD, and despite having an ICD, the hemodialysis patients still had a 2.7-fold higher risk of death compared with those not on dialysis. So it's a pretty disappointing data, and in fact, it shows us that our patients had higher risk of sudden cardiac death. But they have more complications and less long-term benefit after receiving an ICD. So the question always remains: should we be doing clinical trials to more definitively get this answer? As most of this data has been observational. So ideally when you think about a therapy, you want something that's high benefit and low risk. So you want something out here. Really, we've seen patients in dialysis, they have high risk and low benefit. And so knowing this, the question arises, well, what about the CKD population? Do they fall somewhere else on this curve? So next I'm going to review data looking at the rates of complications as well as outcomes after an ICD implantation amongst patients with chronic kidney disease not on hemodialysis. So the first question we asked, so this is all part of the risk study, is do patients with CKD have more inappropriate shocks? So there is a hypothesized risk that's been perceived to be a barrier in terms of ICD implantation, that patients with chronic kidney disease and dialysis have greater prevalence of metabolic derangements, electrolyte abnormalities, and higher prevalence of supraventricular tachycardias, things like atrial fibrillation, which may inappropriately trigger the device to deliver an inappropriate shock. And inappropriate shocks are pretty miserable. As you can imagine, patients don't like them. They hurt. And, study after study has shown that they lead to poor quality of life and are linked with higher rates of mortality if patients with ICD receive inappropriate shocks. And so studies have tried to look at this in patients with CKD. Do CKD patients actually have higher rates of inappropriate shock, or is this all a hypothesized risk? Those prior studies have had some limitations. They've been small. There's been limited number of patients with chronic kidney disease. The ability to differentiate what's an appropriate versus inappropriate shock gets tricky. And then there's these things called anti-tachycardia pacing, which is sort of a precursor to the shock that the device starts to deliver as it kind of gears up and recognizes the rhythm. And that's an important part of the assessment in terms of looking at shock rates. So we actually tried to look at this in the risk study, and the primary question was, do patients with CKD have higher rates of inappropriate shocks with an ICD compared to those without CKD? So to look at this question, we studied about 2,800 patients from 7 different centers across the United States who underwent primary prevention ICD over a 3-year period. About 50% of these patients had chronic kidney disease, and we followed them for 3 years. The devices were interrogated and adjudicated by a committee of EP physicians to determine appropriateness of the ATPs and shocks. So getting around this idea of whether is appropriate. So they looked at every rhythm strip for these devices. So it was quite rigorous in terms of getting this data. And so this table is looking at the rates of inappropriate shocks and ATPs across EGFR category. So I really want you to focus in on the inappropriate shock category. So overall, we see that there was about 10% of the patients in the study had inappropriate shocks. And in fact, there did not seem to be a difference. And if these looked actually lower, the rates of inappropriate shocks looked lower in those with CKD. We then did multivariable modeling to test the association of CKD with risk of inappropriate shocks, adjusting for lots of different things, demographics, lots of different comorbidities, and medication use. And really what we see is that there was no difference based on CKD status, whether you were at a higher risk of inappropriate shocks. So besides shocks, what about other ICD complications? So this is a study that was published in JACC a few years ago looking at complications associated with ICD implantation across stages of CKD. And they looked at in-hospital complications, 30-day complications, and 90-day complications. And really the only thing that was statistically significant in their analysis in terms of looking at rates across CKD stages was rates of cardiac tamponade or pericardial effusion. Everything else looked quite similar, which is reassuring. So we've showed you that CKD patients do not appear to have a higher rate of complications, either shocks or other things. But what about long-term outcomes? So there's been this is a listing of some of the clinical trials that have gone on in the last 20 years looking at ICDs. And, some of them did include a subset of CKD patients. And so what can we extrapolate from these studies? So I summarized, here's the name of the study, the N, the inclusion criteria, the intervention, so all of them compared ICDs with some sort of medical therapy. And then I included whether they had baseline renal function available and if they actually did a renal subgroup analysis. And you can see that most of them actually did not even collect information on baseline kidney function. And only one actually did a renal subgroup analysis. That's the MADIC-2 trial, and I'll show you data from that shortly. So not a lot that we can extrapolate from these really rigorous, well-done clinical trials, which is a little bit disappointing. So the MADIC-2 trial. So this was a trial of 1,200 patients with reduced ejection fraction heart failure that randomized patients to primary prevention ICD versus conventional medical therapy. And then I gave you here the number of patients stratified by EGFR. So majority of them did not have CKD. A substantial number had kind of moderate early CKD, 387, and then 80 patients had EGFR less than 35. And this is their mean EGFR and their mean serum creatinine in milligrams per deciliter in each of these groups. And so what they showed was the following. So this is the 2-year probability of all-cause mortality. They've looked across EGFR categories here. The black bars represent those patients who received an ICD, and the gray bars represent those who did not receive an ICD, those who are treated with medical therapy. And you can see that for that group above 60, that first of all, the rates of death are lower in this black bar, those who received an ICD, and there's a difference in the height of these bars, showing a benefit. Same thing with those in this 35 to 59 category. But if you look at those with EGFR less than 35, all of a sudden you see that there's no benefit in terms of ICD, in terms of rates of 2-year death. And so they showed from this that ICD did not reduce the cause of all-cause mortality or sudden cardiac death in this low GFR group. Some caveats to this data. One, it's a trial that was conducted a long time ago. Medical therapy has changed. So keep that in mind. Again, as we mentioned, there's issues with kidney function in terms of how is ascertained in all these trials. And then finally, it's a relatively small group. It's 80 patients. So other studies have tried to do something similar. This is a meta-analysis of 3 clinical trials that were done looking at defibrillators. And they pooled these patients to make 2,800 patients, and then they stratified them by EGFR, so CKD or no CKD, and those with defibrillators or not. So these 2 bottom lines represent those without CKD. And you can see that, first of all, the rates of death are lower in these groups. So this line, let me just back up. This line is those with CKD These 2 lines represent those with CKD, those who did and did not receive an ICD. So overall, the survival is lower in these 2 groups, and there's no difference between these lines, showing no ICD benefit. In contrast, you see survival is greater in those who did not have CKD, and there's separation of these lines showing benefit of an ICD. So again, reinforcing this idea that patients with CKD are less likely to derive a survival benefit from placement of an ICD. And a recent paper actually looked more closely at this EGFR less than 30 group, and they took 108 patients, and they matched them to those who received an ICD and did not receive an ICD. And again, you see that in terms of survival rates, these look nearly identical. So again, no benefit. So I've shown you so far that in the CKD group that patients don't appear to be at a higher risk of inappropriate shocks, and that there does not seem to be higher rates of other peri-procedural complications. Yet, so the data that we've seen so far from observational studies and post-hoc analyses of these older clinical trials suggests no mortality benefit with an ICD in patients with CKD. However, all this data should be taken with some caveats. All these studies have been modest sample size. That last study I showed you had 108 patients, relatively moderate stages of CKD. Again, there are largely data from post-hoc analyses of select clinical trial populations, which may not be generalizable to the patients we see every day in our clinics. As I mentioned, some of these clinical trials are now over 20 years old. An important part of some of these observational studies is thinking about medication use, and most of them have not had great rigorous data on concurrent CVD medication use, which would influence their rates of death. And then many of these studies, particularly many of the studies actually did not have a comparison group. They actually looked only amongst those who received an ICD and didn't lack that comparison group of those who did not undergo ICD implantation. So we recently published a paper trying to look at this further in a larger contemporary population to really try to answer this more definitively. And it was just published a few months ago. And so our goal was really to examine the risk of long-term complications and outcomes in a population of patients with CKD who did and did not receive an ICD. Again, we wanted real-world patients. We didn't want clinical trial patients. And we wanted a contemporary population, one that we can extract data and apply it to our clinic setting. So to do this study, we studied nearly 19,000 patients who had reduced EF heart failure, who were eligible for an ICD, again, from 4 HMOs from across the United States and different geographical regions. We included patients with CKD who did as well as did not receive an ICD. And statistically, we tried to use emulated clinical trial as best as we could using these real-life patients, kind of merging these two approaches. So we used an approach called high-dimensional propensity scores, which is similar to a traditional propensity score where you match participants, but we take an agnostic view of creating this propensity score because there's all these confounders that you don't know about. If someone's in a certain part of the region and has one provider, that might be a confounder that you can't account for. So it's a sophisticated computer program where you put in all these variables and the computer figures out what the propensity score is. So it's an agnostic approach, and it's pretty powerful. And, we put in hundreds of variables, and it created a propensity score based on over 200. So quite rigorous. We then matched patients 3-to-1 based on this propensity score of CKD patients who did versus did not receive an ICD. And so this is our consort diagram. So out of the 19,000 patients that we started off with over this 7-year period who were eligible for our study, by the time we matched patients by their propensity score and limited it to those who had CKD, we were left with 1,500 patients who had CKD who received an ICD and 4,300 patients who had CKD and did not receive an ICD. Our primary outcomes were all-cause mortality, and we're also interested in hospitalizations, realizing that these patients get hospitalized a lot, and it's a huge cause of morbidity. So heart failure hospitalizations as well as any cause hospitalizations. So these are our characteristics. When you do a propensity score match, you want the two groups to look as similar as possible, right? You've tried to take away all these other confounding variables. So this is a snapshot of what our population looked like. So again, we have about 1,500 patients with CKD who received an ICD and 4,300 who did not receive an ICD. And we're looking at the D value here, so which is kind of another spin on a P value, but the higher the D value, the more imbalanced the groups are, and usually a D value greater than 0.1 is considered statistically different. And so what we see here is that you can see our mean age was about 72 and did not differ across the groups. We had about 70-something white participants, about 14% Black participants. We had some Asians as well as some Native Americans, very few. We had some patients of Hispanic origin. Overall rates of smoking were similar across the two groups. The one thing that did differ across the groups was the ejection fraction, where those who received an ICD had a slightly lower EF, 27% versus 29%. But rates of coronary artery disease were also a little bit higher in patients who received an ICD, 37% versus 30%. Stroke was similar. Atrial fibrillation was relatively close, and as well as other comorbid conditions. If looking at eGFR levels, so the mean eGFR was about 43 in each group, and those were carefully matched, and so those did not differ. So a moderate CKD population. We then looked at the probability of survival amongst these two matched groups, and looking at, so this is all-cause survival, and you can see those without ICDs and CKD were represented by the black line, those with ICDs and CKD, the gray line, and you can see these two lines are very close together, although this p-value is marginally statistically insignificant. I would say there's no difference between these curves. We then did multivariable modeling. So not only did we match participants by this propensity score, this high-dimensional propensity score, we just said, well, what if we still have some residual confounding? So fortunately, we had so many patients, we had the power to do this. Then we additionally adjusted for all these covariates, again, trying to get at confounding as best as possible. So we adjusted for demographics. We adjusted for comorbid diseases, everything you can think of that could be associated with this. And then, importantly, we adjusted for baseline use of cardiovascular medications. And the nice thing about this data set that we're using is that they have very rigorous pharmacy data, and all the patients get their medications from the central source. So we could look at duration of therapy, the doses of medication they're getting, so pretty rigorously, which was a strength of the study. And so in comparing those who without ICD and those who did receive an ICD, you can see that the rates of all-cause mortality were fairly similar between the group, a little bit higher, actually, in those who received an ICD. And then when we modeled this, adjusting for all of these things amongst this matched group, you see that, in fact, there's no association between ICD implantation and risk of death. So from this, we found that ICD implantation was not associated with a lower risk of all-cause mortality amongst patients who had chronic kidney disease and heart failure. We then looked at heart failure hospitalizations as an outcome, again, looking at these two groups. And in comparison to our mortality curves, now you see that there is a difference in that those who received an ICD actually had higher rates of heart failure. This is looking at heart failure-free, survival-free time. So kind of flip it around to think about this. But yeah, so those who received an ICD had higher rates of heart failure hospitalizations. And then we looked at any cause hospitalizations, and you can see, again, these two groups look pretty different. They kind of come together at the end here when we have less follow-up, but they separate out pretty early and stay separate. So then, again, we did the same sort of modeling that we did before, adjusting for those series of covariates, including medications, in these three series of nested models. So this first outcome is looking at heart failure hospitalizations. It's comparing those who did not receive an ICD to those who did receive an ICD. You can see, looking at the rates, that those who received an ICD, the rate was 16.9 per 100 person years versus 11.12 per 100 person years for those who did not receive an ICD. We then, this first model adjusted for demographics. So those who received an ICD had a 60% greater risk of having a heart failure hospitalization. When we adjusted for comorbidity and laboratory values, this was really stayed the same. It was not attenuated. And then when we adjusted for cardiovascular medications, again, there was a significantly higher risk of having a heart failure hospitalization amongst those who received an ICD, where there's a 49% higher risk. We then looked at hospitalizations for any cause, and this could include, complications with the defibrillator, could be anything. And so what we see, again, is that thinking about the rates, we see that the rates of heart failure hospitalization was 52 per 100 person years. It's quite high. Half of them are getting hospitalized. It's quite incredible, versus 38.27 for those who did not receive an ICD. When we did the multivariable modeling, again, model 1 adjusts for demographics, 2 adjusts for comorbid diseases, and 3 medications, you see that this point estimate really stays about the same, where in the final model, there's about a 25% higher increased risk of an any cause hospitalization amongst those who received an ICD. So we showed from this data that ICD implantation had low benefit and no benefit in terms of mortality, but in fact was associated with a higher risk of hospitalizations in patients who had CKD and concomitant heart failure. So to summarize, I've shown you data that shows that heart failure and sudden cardiac death are common in patients with chronic kidney disease. Patients with CKD and ESRD are less likely to receive a primary prevention disease despite those indications. But maybe that's not a bad thing, because the data I've showed you is actually a little bit disappointing. We've seen in observational studies in dialysis patients that the risk of ICD clearly outweigh the benefits. And our data in CKD patients, I would say that the risk of hospitalizations was real and concerning and without any mortality benefit. So it really makes you think, what are we doing and whether we should be putting ICDs in these patients? And I think there's a lot of unanswered questions clearly in this area. Everything I've shown you has been observational pretty much. Even our study, we did our best to emulate a clinical trial, but in the end, it's not a clinical trial. Is observational data enough? A question for the group. Would you want to see a clinical trial to definitively answer this, to be able to inform your clinical practice? And I hate this idea of renalism, that patients with kidney disease are withheld procedures or devices because of CKD, and I don't think the message should be we shouldn't treat these patients. But I think what I've taken away from this whole field of study is that cardiovascular disease in CKD is not cardiovascular disease in other populations. The mechanisms are different, the pathophysiology are, and this one-size-fits-all approach can't be applied to our patients. The same therapies that we use in the general population are not effective in our patients, and so we really have to understand why these patients are having sudden cardiac death more, what's going on with their heart failure that's putting them at risk of this, and actually think about therapies that specifically target those mechanisms, rather than taking any other therapy that's used in other populations and thinking it's going to work in our patients. And so with that, I'd like to thank my collaborators. My main collaborator for this body of work has been Dr. Alan Go, and I've worked with this network called the Cardiovascular Research Network. The studies that I presented, the risk studies, were funded by the NIH, the National Institutes of Health, and I'd like to thank my home institution, where I received a lot of support. So thank you. Yeah.
So for those that aren't used to using this room, this is how you actually ask questions. Press the button and it turns on, the white light, and it turns on. So there are a series of so thank you very much for that great overview. I think it's a little bit depressing on a Friday morning to find out that there's nothing you can do. But I guess for your first question, and I'd throw it out to your group, I mean, I don't know how you'd get this through ethics. If you show harm consistently, it's not like there's equipoise where you don't know, but how do you actually do a randomized trial in something that consistently shows harm and no benefit? And then talk about all the abnormal physiology. So I don't know if maybe we have a cardiologist in the audience who can. Great.
Everyone's looking at you.
So what would you say, Jonas? And maybe use the yeah.
My first thought is there must be some cutoff, right? Some GFR where the harm outweighs the benefit. Do you have any sort of idea on?
Yeah.
We believe it would be sort of beneficial if you have a normal renal function.
Yeah, so it's interesting because the previous studies showed that the cutoff was 35 for GFR. Those all the clinical trials, the post hoc analyses that included 80 patients, but our study actually showed our mean GFR was 43, and we still saw no benefit. So we moved the eGFR, so that was actually quite surprising. And we did look at interactions and stratify, regardless of how you cut it up across the entire CKD spectrum, we saw no benefit. So,
to be honest, those original mortgage trials, they were not really, as you mentioned, not corrected for current medications or comorbidities. So if you adjust for all those things, maybe the actual benefit is less than what you would expect also in relatively.
Interesting.
Yeah, I guess one of the questions is, we talk about renalism or renal nihilism, and whether or not even the therapy, even if you're on the right medicines, not in the right doses or not with the same effect, so you can have the same medications in renal and non-renal patients, but they're not doing the same thing. Or, as we were just mumbling, they might even be toxic. Like, we don't even know if some of the things that we do in renal disease is counterintuitive. So I think it's an interesting problem. And as you said, heart failure is not heart failure is not heart failure if you have kidney disease, and maybe we need a slightly different approach to what we're calling heart failure. Just going to ask Diamond, any questions? Sean, you must have some question that you want to ask. I can't see that he's there.
I'll ask a question. This is Peter, one of the fellows. Thanks for your talk. One of the things I was wondering is just teasing out.
You have to turn on the microphone, Peter.
Yeah, it is on, so I don't know. Is it not projecting through?
Text us the question. We can't hear you.
We were talking about, you asked, Adir and I were talking yesterday about there's a clinical trial that actually tried to happen. It was called the Wedhead trial. It was in dialysis patients. I didn't mention it here. And it was looking at this external defibrillator. And it was run by Chuck Herzog, who's a cardiologist at the Mayo Clinic. And it was randomizing dialysis patients to wear this external defibrillator versus not in that incident dialysis period. So over that first 3-month period. So you're catching patients right when they're initiating dialysis, knowing that the rates of sudden cardiac death are really high. Unfortunately, the trial was terminated early. The device itself was quite cumbersome for patients on dialysis to wear. It was like this very heavy kind of vest. Yeah, I actually wore one. We tried to recruit patients, and it was difficult. So due to low enrollment, it was terminated early. So even at our attempts at a clinical trial to help answer this question was not very successful.
Another question that comes to mind is, did you find any subgroups that potentially had benefit if you look at those, like ischemic heart failure, the younger patients, the more severe or lower deck infections? Find any some kind of peak?
Yeah, I wish we did. So we did test for interaction and stratified by different subgroups. We didn't see any differences across subgroups. One thing to note in our study, though, we only had about 40% of our patients had ischemic heart failure. The rest were non-ischemic, so that could have made a difference. So it wasn't perfect in terms of what you would see potentially your everyday patient, but we did sort of look at the data in all different ways and didn't note any differences. Diabetics, non-diabetics.
Very good talk.
Thank you.
I didn't quite catch whether the risk study was just CKD or did it include dialysis patients?
Yeah, good question. So the risk study that we did focused only on CKD. We did not include dialysis patients for any of the data that I showed you. That was from our group.
Okay, so for dialysis population, there's been a study where they actually implanted with recorders. They found that there wasn't actually ventricular tachycardia. That the arrhythmias that was happening was more bradycardia and atrial fibrillation. So do we know in CKD patients what kind of arrhythmias are happening?
Yeah, great question. So yes, you're talking about there was the MID study that just was published a few months ago that they put in implantable loop recorders and they looked at rates of arrhythmias. So we actually have a paper that we just finished that we're going to be submitting for publication soon, where we took a group of diabetic patients who had chronic kidney disease, and we put not the implantable root recorders, but a patch. So there's these mobile telemetry patches that you can wear. It sits right up here, and it in real time looks at their rhythms, and it gets sent in real time to a monitoring center and tells us what arrhythmias they're having. And so we've had really interesting data from that. So first of all, it was a smaller study. We had about 80 patients in that study. But what we see in CKD patients is that, first of all, there's high rates of bradycardia and conduction abnormalities. And then we saw that about 15%, there was about 15% of new cases of atrial fibrillation that was detected that was unknown previously. And the rates of ventricular arrhythmias were, in fact, quite low. The only sort of ventricular abnormalities we saw were high rates of PVCs, which I've learned from my EP colleagues can kind of, lots of PVCs over time can be kind of the precursor to malignant arrhythmias. And so we saw lots of PVCs, bradycardia conduction abnormalities, and a lot of AFib. And then there's a few other studies that are ongoing that are larger. So there's one study that's going on in the US that's recruiting 1,000 dialysis patients, and they're putting loop recorders in all of them. And then the CRIC study, actually, for this next phase is going to be putting the patch, not the loop recorder, but the patch in about 1,200 CKD patients. So this is certainly an area of interest. And I think you're right. I think maybe, it is not all ventricular. Maybe there's other things going on, and hopefully these studies will give us some insight into that.
Hi, it's James from Diamond.
Questions from the other sites. I'm not sure how easy it is. Oh, James. Yeah. You know what? We can't hear you, so I don't know if someone can unmute the Vancouver site, please.
Can you hear me?
Oh, yeah, that's great. Thanks, James.
Oh, perfect. Nisha, thanks for a great talk. I'm very interested in the data on the shocks that were delivered. I've always had an issue with the ascertainment of SCD in our patients, whether that's actually just too high and whether that's appropriate. In the shocks that were delivered, how many patients actually receive an appropriate shock in the data that you examined? Is that approximate the prevalence of SCD in CKD and dialysis patients, or is that lower than what we would have predicted?
Yeah, hold on. Let me flip back to that slide. I think I had that in there. There we go. Overall, we saw that the rates of appropriate shocks was 18% in the overall study population, and it looks like in those without CKD, the proportion was 20%, and those with CKD, it sort of dropped off where those with the lowest eGFR, about 16% had an appropriate shock delivered. So, these were unadjusted. And then when we looked at the adjusted models, we saw, in fact, that based on this, that there was no difference in the rates of appropriate shocks that were delivered between CKD and non-CKD. So again, getting at your question about are these patients, what's going on with them? Is this really sudden cardiac death or something else? It's an intriguing question. Yeah.
May I ask a stupid question? How is,
sure, go ahead.
In your dialysis population, how is congestive heart failure diagnosed? What was the criteria for diagnosis, and what was especially admissions for heart failure?
Yeah, so our study actually did not include dialysis patients. It includes CKD patients. But I love the question, because this is one of the things that drives me nuts, is how do we diagnose heart failure in our patients in general, whether they're dialysis or CKD? Heart failure is a clinical diagnosis based on symptoms. Many of the symptoms that actually overlap with the symptoms of CKD, shortness of breath, edema, other things. So I think this remains very controversial in terms of how you diagnose heart failure. What is heart failure? Particularly since 3/4, Adir has published on this a lot, 3/4 of our patients have LVH. Is that all heart failure? Now with HFpEF, it becomes even more tricky. It's sort of a mess in terms of thinking about what is heart failure in patients with CKD, because you could essentially say that all of our patients have heart failure based on the current criteria. So there's actually, there was a group that met a few years ago, a consensus group that tried to tackle this and really are pushing for sort of kidney-specific heart failure criteria. So I think it's an important point. I know, exactly.
Peter Burks, you were trying to ask a question before.
Can you guys hear me now on the mic?
Yep. Mm-hmm. Yep.
Okay. Thanks for your presentation. I'm Peter. I'm one of the fellows. I just had a quick question. When the demographic table on the last trial that you guys were doing that you presented, I just saw there was a higher rate of VT in the patients who had ICDs. I know overall they were small numbers. I was wondering how much that might have affected the mortality, because you might expect those patients to have higher mortality, although the absolute number was smaller.
Yeah, that was a good catch. So yeah, there was a higher rate of VT in those who received an ICD. You know, these were all supposed to be primary prevention ICDs, so this was kind of curious. We did do a sensitivity analysis where we excluded these groups, and we saw similar results.
Thanks.
Great. Mark.
Thanks, that was really good. I think the second point you made in your summary slide at the end is definitely the most important, because we're guilty of this a lot, that we're applying evidence from some population and then just thinking what it would say. And for something like this, if it's ICD versus optimal medical therapy, we don't actually know for sure that ACE inhibition and beta blockers are the right thing to do for the kidney population. So if your control group is an unknown, and you want to test an unknown versus an unknown, you're never going to get the answer.
Exactly. Yeah. No, I completely agree. I think we need to take a fresh look at things. You know, there's a big move right now for precision medicine. You know, not only understanding CKD, but subtypes of CKD. I mean, we're at risk of not only applying therapies from other populations, not knowing what our comparison group is, what is optimal therapy in CKD, but I think we talked about this a little bit yesterday. CKD is a mixed bag. Your older diabetic patient with hypertension and diabetic nephropathy is very different than your PKD patient, than your IgA patient. So there's a lot of questions that need to be understood. And so our center is actually very involved with this kidney precision medicine project, where they're actually trying to use omics and other things and get kidney biopsies in large numbers of patients with CKD and AKI to better define, you know, the molecular basis of kidney disease, and that would be the first step in terms of then understanding therapies in these populations and what the ideal therapies are. So it's a great time to be in nephrology, in my perspective, because you know, there's a lot of important questions that that need to be answered, and we can do a lot of good. I think we're just starting to learn about our patients now.
It's a nice positive ending to a Friday morning. But no, I thank you. So it's very sobering that, you know, after umpteen years, we're still talking about cardiac disease and kidney disease like it's one thing, and heart failure and kidney diseases. We have an S now, but we're not so good at it. But I think, as you said, there's lots of unanswered questions. There's lots of things we should stop doing.
Yes.
You know, and one of the things is also to start understanding how the different drugs work at the different levels of kidney function and what is optimal treatment for heart failure, so that you actually don't need your ICD that doesn't work anyways, right? But anyways, thank you very much for a thoughtful and stimulating conversation, and for all of you for participating, and happy Friday.